Namaskar, dear viewers. Sorry for the readjustment in time because of certain internet problems at Dr. Nikhilesh Jain's end. The internet was blacked out for some time. So today, Dr. Nikhilesh Jain is our expert for critical lines. Sir is a very eminent person in critical care in India and has contributed greatly to education in India and also to our platform. So, sir is Director and Operational Head Department of Critical Care Services at CHL Hospital, Madhya Pradesh at Indore, which is the largest hospital and ICU in Madhya Pradesh. Sir is also, or rather was the chairman of the Society for Madhya Pradesh of ISCCM. He was the scientific co-chair for Critical Care 2023 held at Indore, and he was awarded the B. Braun Medical Trust Foundation Scholar a few years ago. So with that introduction, I will now start the critical line session. So the first question to you, Dr. Nikhilesh, is regarding pancreatitis. Rather, the next couple of questions are also on pancreatitis. So how do you really interpret lipase and amylase in the context of suspected acute pancreatitis? What are the final points and how do you interpret it? Please, if you like to talk about it.
So basically, the thing that happens is most of the times when we see elevated amylase lipase, we jump on a diagnosis of acute pancreatitis. Now, we need to remember here that in usual cases, we are talking about at least 3 to 5 times these elevations. And the problem comes when your patient is, say, maybe an alcoholic pancreatitis, maybe a gallstone pancreatitis, or maybe for that matter, a diabetic, wherein the values which are conventionally held to be as higher by 3 to 5 times do not hold true. You need a much higher threshold for that. Now, another question that comes is many of the times we talk about how amylase is relatively non-specific and lipase is relatively more specific. True, but that only means that hyperamylasemia actually is seen in more conditions as compared to hyperlipasemia. And what really happens is both of these conditions have got a lot of differentials. And when we look at it, conditions such as acute renal failure, conditions such as diabetic ketoacidosis, variety of drugs, pancreatic and extra pancreatic causes, certain neoplasms, there's a whole long list available. In case if anybody is interested, we can maybe supply it later on, but it's a huge list wherein you can get falsely elevated amylase and lipase levels. Having said that, even if you get amylase and lipase levels, they are effective for one-time diagnosis only. They have no bearing on the course of the disease. They have no bearing on the mortality caused by the disease, and they have absolutely no bearing on how you know uh, the organ progression to modes or any other complication might happen for these particular patients.
Right, sir. So moving on to the next question, how do you plan hydration and fluid resuscitation in a patient who comes to you with acute pancreatitis?
Right. So now the thing is that most of us have been taught as a traditional dictum that you just pump in fluids like anything, and then possibly these patients do well. Now, there are just a few points to remember. In this, probably you should use your BUN levels and hematocrit levels as sort of indicators to guide your fluid titration. And do remember that if it's a mild pancreatitis, so in mild pancreatitis, there is absolutely no problem in, sort of pumping the patient with fluid. But what really happens is when we are talking about something like what spectrum of acute pancreatitis do you get the patient into? If you get this patient in a way that this patient is having severe acute pancreatitis, then there's absolutely no guideline which tells you how much fluid needs to be given. And 9 times out of 10 in a patient of severe acute pancreatitis who's presenting to you after 24 hours, because there's no guideline in place, if you keep on pumping fluids into these patients, they may go into volume overload. Whenever you want to give fluids, again, traditionally, what is preferred is ringer lactate over normal saline for the simple reason that we nowadays know that normal saline pH is less than 5.5 and it can give rise to a normal anion gap metabolic acidosis if given in large volumes. So try to remember that try to use your ringer lactates. As a thumb rule, giving 3 to 4 liters in 24 hours most of the times is good enough. And keep on monitoring your hematocrits and BUN levels every 6 to 8 hours. The idea is that you hydrate these patients to the extent that they do not develop acute renal failure and elevation of BUN levels. Once they develop that, then you've already missed the bus in terms of volume resuscitation.
So any role for dynamic tools for fluid resuscitation? Can they be used?
True. You have certain dynamic tools, and in that, actually, calculation of intrathoracic blood volume is performed nicely. You can use your ecos to guide your volume overload. How much is your left ventricular end diastolic pressures? You can look at them, and you can actually look at your cardiac index, how bad the cardiac index is, if it is less than 2.2, if it is more than 2.2. So these are things that you can use to guide your volume resuscitation if you're thinking in terms of actually having monitoring parameters. If you're thinking in terms of clinical parameters, development of tachycardia, tachypnea, RALS, or pulmonary edema is some sort of an end time. You can try to use ultrasound lung to look at your B lines. If they're increasing in number, maybe you are over resuscitating the patients. So these are the things that can stand you in good stead.
Right, sir. Thank you for the answer. Next question is again about acute pancreatitis. So, where do we use antibiotics and what exactly is the role of antibiotics in acute pancreatitis?
Okay, so this is very funny, but all the papers which came to us before 2006, they talked about prophylactic role of antibiotics and they advocated it like anything. And something happened to the literature after 2006, wherein two major guidelines, three major meta-analysis and randomized controls all talked about why it is not good to give, antibiotic prophylaxis. Now, having said that, there's still one guideline, there's one Japanese guideline which still tells you that probably giving these patients prophylactic antibiotics is better. But for all exam going people, I would put it that way, whether it is the American Society of Gastroenterology, whether it is certain other guidelines, whether it is Europeans, they all talk about how not giving antibiotics as a prophylaxis matters. Now, why I call it as a, crux like situation is because how do you establish infection? How do you establish that the patient has undergone necrosis? Necrosis is already like more than one-third destruction of the pancreatic substance. So for that, you need to do ideally a fine needle aspiration cytology, FNAC of the pancreas. Now, the problem that happens is with that there is no consensus on the timing and the validity of when you should do this fine needle aspiration. So then again, you go into a catch-22 situation that how to decide on that. So, and then there is another situation wherein if you get a walled off necrosis, you can go ahead and use your antibiotics nowadays, even up to the tune of 4 weeks, so that the collection gets walled off and patient is much better off subsequently and patient is able to avoid surgery. The only indication for surgery nowadays has become a hemodynamic instability, which if acute, then these patients should be subjected to earlier surgery. So there's nothing wrong. I won't find faults if going by evidence in terms of whether you would like to give early pancreatitis or not. But having said that, for all exam related things, if you do not dissect out the evidence, giving early antibiotics is not indicated. However, to establish presence of infection becomes still more tougher because the role of CTFNA is also not been decided exactly where in the literature.
Thank you for the answer. Moving on to PRES, PRES, posterior reversible encephalopathy syndrome. So we
Correct,
know,
sir.
sir, generally it is caused by accelerated or malignant hypertension, and the symptoms are headache, seizures, confusion, amongst other neurological symptoms. So,
Correct.
what are the other causes of PRES? What is the physiology, and how do you diagnose this? And what is the course and treatment of PRES?
So, see, most of the times, all the conditions that can give rise to accelerated hypertension can give rise to press. Let's understand this. It could be something as simple and mundane as eclampsia, but most of the times these patients are picked up and they come to us because they have seizures. Even with minor reductions in minor elevations of BP, these patients can present as press. Having said that, pathophysiologically, elevated blood pressure along with endothelial dysfunction is what leads to white matter edema in all of these patients. And because of that, you get these patients coming with headache, seizures, and of course, certain times visual disturbances. Something very classical is what you diagnose. I mean, this is the triad sort of a thing which you can actually put forward in terms of diagnosing these patients as press. Most of the times press would be seen and you do a brain imaging. When you do brain imaging, you see these patients as something like posterior lesions or parieto-occipital lesions is what you see with sparing of paracrine and calcarine cortex of occipital lobes. Most of the times it is a subcortical pathology. It's not to say that it cannot be seen in cortical regions, but most of the times it is that. And when we talk about treating these patients, so treatment of these patients, one is of course related to treating the conversions of these patients, and second is bringing down the BP. So bringing down the BP, you try to achieve a target of something like 10 to 25% of your BP reduction. If your diastolic BP is say less than 100, if it is more than 100 or maybe 100 to 105, what you are targeting is a 25% reduction in blood pressure, nothing more than that. You can use labetalol very frequently, and you can use certain other drugs to bring it down. Preferable to use IV drugs rather than oral because oral drugs take their own sweet time to act, and it may mean that you are requiring more time to control these lesions. Whatever said and done, white matter edema is what you should be looking at on imaging lab findings when it comes to whether it is flare, whether flare can pick up certain peripheral subtle lesions. When it comes to diffusion weighted imaging, it can actually pick up hypo-intense to iso-intense lesions, which can be a differential with an infarct. With if you get bilateral posterior cerebral infarct, what would you think? So those lesions would be hyper-intense rather than hypo or iso-intense. And that's it, I guess.
Right, so thank you. Then moving on to CRT. So, sir, in CRT, there is supposed to be loss of multivitamins, micronutrients, and amino acids. Now, how do you, estimate the losses, serum losses, and why do these occur? And after how much time of CRT do they occur? And how do you replace them? In which ones do you replace, and in what doses?
Right, doses is very difficult to say, sir, because there are no definitive guidelines for that. In fact, this whole area is mired into a lot of investigations. There are multiple algorithms wherein they recommend routine replacements of certain vitamins and everything. But what is now very widely and well known is it is the effluent which comes out from a CRRT, which takes away micronutrients and which takes away certain vital things for the simple reason that it tends to remove all toxic substances. And with all toxic substances, this also goes through. Now, the clearance is more with convective clear mechanisms rather than diffusive mechanisms. What has been documented in a big way is you get a significant reduction in levels of vitamin B6 and folic acid levels. There are certain studies which talk and say that maybe water soluble like B6 and folic acid levels do not go down that much, but it's vitamin C levels which are lost in a big way. It is the selenium levels which are lost in a big way. And of course, one more trace element that comes up is zinc. What really happens is that you have zinc coming out of the effluent, and simultaneously what they have found is if you are going to use zinc replacement solutions while you are using your CRRT, then probably zinc is able to maintain a decent balance. But as a dictum, remember that there is loss of B1, B6, and B12 vitamins. There's a significant deficiency of copper and selenium, so you need to replace these trace elements. And having said that, there are certain gaps. What happens in 24 hours is you start getting minimal losses of water soluble vitamins, but by 72 hours, losses of water soluble vitamins, losses of selenium, losses of copper get established for all these patients, and patients start getting deficiency symptoms. Obviously, this would mean much more mortality, a higher risk of mortality, a higher risk of developing malnutrition, and of course, a higher risk of these patients would complain of more fatigue and loss of appetite as well.
Right, sir. Thank you. Finally, sir, coming to the last few questions, is there a role for ECMO in pulmonary embolism? And like, how do you go about it if there is?
See, sir, in 2019, there was a statement by AHA which actually put the value of ECMO as an adjunct for patients who have severe pulmonary embolism. Now, having said that, now the position statement has changed, and now they are talking about using ECMO actively. Now, ECMO actively for what reasons? Obviously, a lot of people talk about whether to use VV ECMO or VA ECMO. VV ECMO does improve oxygenation, but what you're looking at is your right ventricular, unloading. So, right ventricular unloading can only happen when you use a VA ECMO, which is more preferential. Then you have a situation wherein what are the type of patients where you would like to use them? Of course, it has to be a witnessed arrest. The patient has to be less than 70 years of age. It has to be a VF, pulseless electrical activity, which would take into consideration that it's witnessed and it has happened in the hospital, of course. So these are the type of candidates that you are considering for VA ECMO. Another thing that you will now still you should remember that when you're going to do or going to offer them VA ECMO, there will be plenty of complications that might happen with these particular patients. And there are two, three scores that probably you should remember that. One is the pulmonary embolism severity index, and another one is called as SPC. This is actually again used for patients who are going on ECMO. And then you have got certain scores, There's a SOFA RV score, which refers to the right ventricular thing, in which the higher the score, the more the mortality, and there's a SAFE score. Again, which talks about, these patients going on ECMO, and again, higher the score, more the mortality. So all these patients, when they are put on ECMO, there's still no consensus as regards to how they will fare. But yes, there is a statement which says that these patients can be used, one, as an acute salvage therapy, two, as a bridge to definitive therapy in the form that they can be taken up for definitive surgical processes or peripheral embolectomies later on. And thirdly, of course, as a matter of continuing these support based on your SAFE scores and SOFA RV scores. But as a blanket role, I would not recommend that. And definitely in a patient who is less than 70 years of age, patient who does not have any terminal disease, patients who do not have a major liver dysfunction or a major CKD or CLDs and all those subsets, those are probably the people who are the right candidates for this.
Right, sir. Thank you, sir. So we just have time for one more quick question. So we'll just go on to pancreatitis. So how do I plan and what is the role of imaging in acute pancreatitis?
Right, sir. So when we talk about acute pancreatitis, if there is any acute deterioration, then you should think about it. Previously, there used to be a dictum that you can take, say, maybe 2 weeks and then you do your Balthazar scoring and all those things. But any acute deterioration, you do an imaging. Anything more than 72 hours, once you've seen the patient, you do an imaging for the simple reason that we do not know whether the patient is presenting to you and on an initial stage of pancreatitis or whether the patient is presenting to you with severe acute pancreatitis. And as I told before, if your patient is already having MODS, then again you have to do it. If you need to establish a necrosis, then you have to do it. And again, if you want to establish when you want to give antibiotics to these patients, a CT guided FNAC, as discussed before, would be your investigation of choice for these particular patients.
Right, sir. I think that was all. Thank you so much, Dr. Nikhilesh, sir. And I thank the audience for their viewing. Thank you, everybody. Till the next critical lines. Thank you, everybody. Good night. Good night, sir.
Thank you, sir. Good night.